Sana,
Yes, sir, it's audible.
my screen is visible.
Yeah, screen is visible.
Okay. Good evening, all. We'll start with the today's topic: approach a child with polytrauma. Mainly, we're going to discuss about the ATLS guidelines. So, I feel many of us already performed or participated in Paul's pediatric advanced life support. So, there are certain differences when you approach a child with polytrauma from this Paul's guidelines to ATLS guidelines. So we'll see what are the main differences and how to approach a child with polytrauma through a case-based discussion. This is about a 14-year-old male child who was brought to our ER with alleged history of road traffic accident. So he was traveling on a bike and hit by a high-speed car. So at the stage, he was found unconscious and he was brought to ER by a monitored ambulance. So initial impression, so child was unresponsive and his increased work of breathing was there along with the stridor, and his peripheries were pale in color. So based on this, what is the physiological status of this child and what are the causes of stridor and what is the intervention we need to plan here?
It's an unstable life-threatening condition, sir.
Okay. Yeah, it's unstable life-threatening condition. So what could be the cause of stridor here?
So any pooling of secretion because of tongue fallback.
Good. Pooling of secretions, tongue fall back. Any other thing? Okay, move on. What is the intervention you want to plan here?
Airway, so oropharyngeal airway.
So you want to
Suction and oropharyngeal airway.
suction and oropharyngeal airway. Okay. Any other thing?
Sir, jaw thrust.
Jaw thrust. Okay. Any other thing? What position you want to keep?
Left lateral.
Left lateral. Okay.
No, sir, no.
Okay, we'll move on. So accepted is unstable life-threatening condition. So the cause for stridor could be the pooling of secretion of tongue fall along with the loss of airway tone, mainly because of your CNS thing. And apart from that, there is a direct trauma to your larynx. That is very rare, but it comes to be possible. Your facial trauma with laryngeal trauma can also cause a localized hematoma, which is compressing the airway, upper airway. So these are the causes for the stridor, but the common things are pooling of secretions, tongue fall, and loss of airway tone. And intervention, as usually, like we discussed it, we need to start a child on 100% oxygen by NRM. And lateral position, which is what we actually do for any child with this kind of scenario, neurological scenario. We'll clear oral secretions and we'll ask for IV cannulation to be inserted and we'll move on to primary assessment. So what are the things which are wrong in this intervention here, which we should not do here?
Putting the child in lateral position before stabilizing the spine.
Exactly. So there is no lateral position in ATLS. Any other thing? So it's little bit different. It's not primary assessment in ATLS. It's primary survey. So there are certain differences from our routine primary assessment in PALS to primary survey in ATLS. So we'll see what are the main differences. Can anyone elaborate what is the primary survey in ATLS? There's only certain few differences. The other things are same. It's ABCD only again.
Sir, in D, we will look for neurological
Start with
deficit.
A. Always start from head to toe or toe to head. Don't start in between. So what is ABCD in primary survey in ATLS?
Airway along with cervical stabilization, sir.
Yes. So apart from airway, you need to stabilize the cervical spine, which is most important. Next,
And breathing is same, and in circulation we should do hemorrhagic control also.
there is something in breathing as well. You need to add something to breathing as well. Okay. See.
Circulation along with hemorrhage control, sir.
Good. D.
Disability, sir.
D is same for disability. E.
Exposures.
Exposure along with environmental control. So these are a few things which is different from our primary assessment, which we don't do in falls. In primary survey in ATLS, the main thing is apart from your airway maintenance, you need to clear-cut focus on stabilizing cervical spine. Because of this injuries to the head, there may be damage to the cervical spine as well. So if you don't stabilize your cervical spine or you restrict the motion of the cervical spine, it can lead dislocation of atlantaxial joint and it can cause damage to cervical spine. So what will happen if you damage cervical spine? Cervical spinal cord. If you say damage or transaction cervical spinal cord, what will happen?
Paraplegia.
So you'll get a paraplegic chill. So you've done a very good job by putting intubation, breathing, shock control, other management, and finally you give a paraplegic chill to the parents by just simply not following cervical spine motion restriction. So always focus. And the moment if you hear that you are entering into an emergency room where the polytrauma child is arriving, so you need to move to enter the room with your hands in the position to stabilize the spine, not with the free hands. You have to keep your hands in a position which will be useful for stabilizing cervical spine. So we'll see. I think I sent the video also already. So how to stabilize cervical spine, everything. Just if you're not gone later the class, you people can go through the video. So another important thing is breathing. So routinely we'll see what the osculator findings, everything, and the SpO2. Apart from that, we need to see whether the child had any problem with the ventilation. Is there any thing which is causing restriction of ventilation, like pneumothorax, your hemothorax? So any injuries which is fly chest, which is causing problem with the ventilation. So that is what you need to see extra things apart from the routine things you see in pulse. And in circulation, apart from your assessment of shock, and the main important thing is you have to control the hemorrhage. You all know that the most common cause of shock in trauma is hypovolemia secondary to hemorrhage. So your aim is not only resuscitating the child. Apart from the resuscitation part, you need to have a clear-cut plan how to control bleeding. So how to control bleeding? Any examples?
Binder.
Pressure application.
Yeah, local pressure application.
Tourniquet we can tie proximal to the injury.
Exactly. Tourniquet.
Binders.
If you found a vessel, you can clamp it directly, open wounds. So these are the methods we can use to control hemorrhage. So how much amount of resuscitation you are going to do? If you don't control hemorrhage, you cannot succeed in stabilizing the hemodynamics. So last thing is environmental control. So mainly environmental control is you need to move away the child to a safe environment before starting resuscitation. So you cannot start resuscitation in unsafe environment where you also can be unsafe. So that's the most important thing. So with these things in the primary survey, we'll quickly move on to the next thing. So next thing is airway maintenance. How to maintain airway?
Jaw thrust.
Jaw thrust. Okay, only jaw thrust.
head tilt, chin lift, and jaw thrust, sir, but probably jaw thrust is preferred when the cervical injury is there.
Okay. Any positioning apart from jaw thrust? So your jaw thrust is mainly to open the airway, and for the positioning, what position we need to keep? So if in infants and the smaller children, you keep them straight on the bed,
Slightly extended head.
your neck will be flexed and your airway will not be maintainable. So we need to put them in a position where your facial plane is very parallel to the your surface ground. But you should not cause too much extension. You cannot put like a roller, like a bedsheet roll under the shoulder to make it. So you need to put a 1 inch thick padding under the body, so that the head will tilt little bit, so that the plane of the face is directly parallel to the plane. What is sniffing position? What is the difference between sniffing position and what the position we are talking now?
In sniffing position, the glabella and the forehead will be in the same plane, and the external auriculus and external meatus and the suprasternal will be in the same plane, sir.
Okay, can you tell me how you do that sniffing position apart from this? What we done with 1 inch padding? So how it's going to be different? How different you are going to do?
We'll be putting a shoulder roll and a head support also for the sniffing positions.
With a little extension of the head, extension of the neck. So you should not follow sniffing position here. This is a sniffing position. So by putting sniffing position, you are making all the axis, pharyngeal axis, laryngeal axis, and oral axis in a similar plane. So by putting something under the head and extending the neck. So that extending part you cannot do here because you are suspecting cervical spine injury. So instead of that, just we are going to make the facial plane parallel to the ground by just putting 1 inch padding underneath the body. So it's not sniffing position, don't forget. So the commonest mistake what we are going to do is we during intubation and opening the airway, we are going to put them in a sniffing position and make the head extension. So extension of the head should not be done in trauma children. And jaw thrust, exactly. So there's no head tilt and chin lift for maintaining the airway. So we need to do jaw thrust by simultaneously pulling the angle of jaw forwards with 2-hand technique. And if the question is here is, if you're not able to open the airway with the jaw thrust, what you can do? So you done the positioning, you did the jaw thrust, till you're not able to get the airway open. So
Airway devices.
Yeah, I couldn't able to hear.
Airway devices, like we can put an oral airway
For that,
or nasal airway or oral airway.
for that. Positioning, just I'm asking about positioning and opening airway before going for any other things. Is there anything you can do? Just changing the position or some other maneuver to open the airway. So you can try chin lift without head tilt. You can just attempt a chin lift to maintain the airway. The first preference is jaw thrust, but even if after jaw thrust you are not able to maintain the airway without head tilt, the common thing is mistake is we'll next moment we'll move on to the routine head tilt and chin lift. So without head tilt, you can try chin lift. That is the last resort before going for alternate airways. So exactly like you told, airway maintenance, the first thing is position. Second thing is you have to clear the secretions, what you clearly discussed. And someone answered oral airway, so you can try oral airway as well. And the other things are the alternate airways like LMA. And if you clear all these things, what we can have? So you put the position, you done the maneuvers, you clear the secretions, you tried oral airway, you tried LMA, you're not able to maintain airway. So what do we have to do here?
Intubation.
Yeah, you need to proceed for intubation. There's no alternative apart from this. So coming to cervical spine stabilization, what are the methods of cervical spine stabilization? How to stabilize? LMA is laryngeal mask airway. It is a simpler one without any use of laryngoscope. You can blindly insert it so that its opening will be adjacent to the larynx and laryngeal opening, and you can give bag and mask bag through LMA. So it's just urgent when you're not able to intubate. Before intubation, you can try that. Yeah, cervical spine stabilization.
Cervical collars you can use, sir.
Cervical collar. What type of collar? How many types of collars are there? What is the normal collar? What you use for adults? Some people are in cinemas also. They're putting some collars in the neck.
Soft collar, sir.
Is it advisable here?
No, sir.
Yeah, it is. It's hard collar. Before that, before putting collar, how to stabilize?
Inline, sir.
Yeah, manual stabilization. So you need to go for inline manual stabilization on cervical collar. Then any other methods? So one is manual stabilization, one is a hard collar. Third thing is by using the blocks, saline bottles, sandbags adjacent to the your head, and you can strap them. So you can put the blocks and you put the head straight and you strap the head and the chin, forehead and chin to these bags so that it will not move. So these are the different methods of cervical spine stabilization. So this is the manual inline stabilization. You stand at the head end of the patient and put your hand in this as shown here. And like main thing is you should not allow the head to move in sideward direction or extension flexion. So you're restricting the motion in always, not only flexion extension, you need to restrict the sideways motion as well. So that is the thing you need to apply. And simpler thing is you can just hold the head and keep it straight without extension flexion. Even that is also you can do. So these are different techniques in manual inline stabilization. There are a lot of YouTube videos available freely. So you can go through how to do manual inline stabilization of C-spine. There are different techniques. And this is the hard collar which you use for stabilizing the cervical spine, and you should not use soft collars like this. So I think many centers are using still soft collars, thinking that it's going to protect it, but no. Please avoid soft collars, and you can get hard collars. It's easily available in Amazon. It's available. There are two companies which is providing this. One is Ambu company, and another thing is Lardial company. So you can easily get it. It's hardly like 400-500 rupees. That's all. And most important thing is when to apply cervical stabilization of cervical spine. When if a child is coming walking to the ER, can you apply cervical collar? So what are the indications for cervical spine stabilization or restriction? So when you want to put cervical collar?
When
So
there is
multiple trauma patients, sir.
So unconscious patient.
Exactly. So unconscious patient. Why you want to put a collar for unconscious patient?
we don't know whether the cervical spine is injured.
Exactly. So unconscious means already you know there is a injury to the head. So if that much impact injury to the skull, it can cause some amount of impact on the cervical spine as well. So we are assuming that. So all unconscious patient, the injury to the spine is injury to the head is the force is very higher force. So some impact will be there in the spine as well. So we are assuming and we are stabilizing the cervical spine. So all unconscious patient, you need to stabilize cervical spine. It's no question here. So next thing is the patient is conscious. Does you want to put cervical collar or not?
Conscious with restricted movements and pain over neck movements. Then also.
Good, excellent. So this is the guidelines given by pediatric, some ortho society. Is a consensus guidelines on clearing cervical spine, and it's freely available on the net. So if your GCS is like normal, like 14 to 15, so you need to ask for history of any neck pain, abnormal head posture like torticollis, difficulty in neck movement, either any focal, sensory, or motor deficit in the lower limbs. So we need to think of all these things, and you haven't seen any significant injuries, high force injuries to the chest, abdomen, and pelvis, thinking that there might be some amount of impact of cervical spine as well. So in that people, you need to first stabilize. Then only you think of investigations. Don't go for investigation before stabilization. If you suspect there is a cervical spine injury, you need to stabilize it first. So workup and clearance is later. So for ER management, we should know when you need to stabilize cervical spine. If a child coming with a normal GCS, and if you feel there is this kind of findings are there, so persistent neck pain, abdominal head posture, difficulty in neck movement, motor deficiency deficits, and there's a strongest substantial injuries are stronger to the regions. So you need to think of stabilizing, and always then you can once stabilizing the cervical spine and stabilizing the child, then you can move on and you can take, you want to take X-ray, you want to take CT spine. So that's entirely different. You can do it later, but before that you need to stabilize the cervical spine if you feel all these things are there for the child. And as you feel, if you're a very unconscious child, then definitely you need to stabilize cervical spine. And if GCS is 9 to 13, immediately you can move on to chest X-ray, neck X-ray, and look for this thing. If X-ray is fine and examination is normal, then you can clear C-spine if the mentation is improved. But if the mentation is not improving, then you need to go for CT. So make it simple. Any child with altered sensorium less than 13, you need to stabilize cervical spine. If cervical spine is stabilized and child sensor is improved, whether you want to remove cervical collar or not, that depends on your imaging findings. Whether you want to take X-ray or CT, it's depending on your GCS. If GCS is less than 8 persistently, you need to go for CT, no other go. But if your sensor is improved, then you can go for X-ray, and if X-ray is normal, then you can clear C-spine. Even if your X-ray is normal, plain X-ray, then you need to, if you're suspecting strongly, you need to obtain flexion extension radiograph. Sometimes there's some mild laxity of the things around supporting this cervical spine. They can become lags, like these tendons and the ligaments can become lags. So when you do flexion extension X-rays, sometimes you can detect the wide gap in the cervical spine. So it is mainly for subtle injuries to the ligaments. So bony injuries, then you can pick up in the plain radiograph. But if it's strongly suspecting some amount of ligamental injury or soft tissue injury, you need to obtain flexion and extension radiograph if the sensor is becoming normal. Otherwise, it's safe to put the cervical collar in place and do the cervical spine restriction and get the spine ortho or neurosurgeon consultation and go for C-spine, CT spine or MRI spine before you're removing the restrictions. So make it simple. So altered sensorium provides this installation. Normal sensorium with any findings, abnormal findings, go for stabilization. And clearance of cervical spine stabilization is based on X-ray or CT depending on GCS. So for this child, we'll quickly move on to the primary survey. So this child airway is not maintainable. And it's a breathing ventilation wise. Child had tachypnea. This is a decreased air entry on right side. Has tried air, even with oxygen, SATs are 88% only. And coming to circulation, his heart rate was 160, 14-year-old child. Pulses are low, peripheries are cold, prolonged CRT, BP is low. So disability wise, Jesus was 7/15, pupils are unequal, GRS is okay. Exposure wise, this right thigh swelling is there and multiple abrasions and lacerations are there. So what are the issues you identified here and how you want to intervene?
So airway is not maintainable, so we'll intubate the child. We'll C-spine stabilize. We'll stabilize the C-spine, and because the air breathing wise the air entry is decreased, we'll pertus and see, and whether we'll see any trachea is shifted to one side or any mediastinal shift is there. We'll rule out pneumothorax.
Okay. So can you list out the problems here before going for intervention? We'll just list out the problems. So there is a first problem you are told correct airway is not maintainable. Second problem in breathing.
Before stabilizing the spine, we'll just see whether we'll just have a look on the net, sir, whether the trachea is in midline or shifted to one side, and we'll see when any other main vessel injury is there or not.
Okay.
Sir, pelvic trauma we can rule out because right thigh swelling is there.
No, you come ABCD wise. So A, we've seen there is a problem, airway is not maintainable. In B, what is the problem here?
Air intake is decreased, sir. We have to percuss and find out whether it is due to pneumothorax or it could be hemothorax also. So we'll percuss and
Before that, what is the problem here?
Respiratory distress.
It's respiratory distress or something else classification.
వాళ్ళది మనకి వినపడ మంది వాళ్ళకి వినపడదు.
It's respiratory distress failure.
failure.
So it's respiratory failure. Understood. Fine. Then you are suspecting pneumothorax. If percussion wise it is dull,
Hemothorax, sir.
you are assuming that there is a problem with the right side lung as well in the pleura. Okay, fine. Circulation wise,
Shock is there, sir.
what shock?
Hypotensive shots.
Hypotensive shock. What is the cause for shock?
Hypovolemia, sir, maybe due to bleeding.
Okay,
Or pneumothorax can be leading to
good. So you are suspecting hypovolemic shock and obstructive shock. Good. Any other shock you can find here? Okay, we'll move on. Disability wise,
GCS is 7, sir, so
so it
less is indication for intubation, sir. Can be
what is the problem here?
to bleed, so
So, okay,
Cerebral dysfunction.
primary or secondary?
Intracranial bleed cell is
So it is primary or secondary? It's a cerebral dysfunction. Yeah, someone answered neurogenic shock, 100% correct. So you can have 3 types of shock in this child. And you have primary cerebral dysfunction and you have a catchy point there. Pupils are unequal. So what exactly is happening there?
Increased ICP, sir.
Increased ICP? What level of ICP? Early, mild, moderate?
Severe, sir, final, because
That means what is happening there? Child is at the verge of coning or herniation. So first thing is herniation, second is moving towards coning. So you need to act very quickly here. And someone is pointed out right thigh swelling was there. What is the reason for right thigh swelling?
internal bleed due to fractures.
fracture femur, sir.
The fracture femur leading to bleeding. So that is the reason for your thigh swelling. Okay, so we identified the problems now. So we have identified the multiple problems at every level. So airway is problem, breathing is problem, ventilation is problem, circulation is problem, disability is problem, exposure is problem. So how you want to intervene now? First coming to airway. So how you want to intervene now?
Intubate the child, sir, because it is not maintainable.
Okay, good. So what are the precautions you want to take while intubating this child?
C-spine stabilization.
So C-spine stabilization, how we want to do C-spine stabilization during intubation? The next question is, can we intubate a child with neck collar? Can we intubate a child with neck collar? No. So how to stabilize?
One person should manually stabilize the cervical spine, sir, so that the other person can intubate.
Good. So always you need to maintain cervical spine immobilization. The main problem with collar is you cannot intubate with the collar in position. So we need to relax the collar, and someone has to take over the manual stabilization. And the person can sit down at the head end and stabilize the spine. Then the person above can intubate this child. So that is about intubation, and this is about cervical spine stabilization. What other precautions you want to take during intubation? So this is stable scenario for intubation, and it's unstable scenario for intubation.
Unstable child.
So unstable. So what instability you are expecting here? What instability you are expecting? Does the child can go for arrest or any another mishap can happen for this child during intubation?
You have to minimize the pressure, maximize the pressure first by giving bolus.
Yeah, it's a physiological difficult airway. And if you have an injury, if you have seen that some injury to the facial bones or neck thing, then it can become anatomical difficult airway as well. So always look for difficult airway when you're proceeding for intubation. Think about this anatomical and physiological difficult airway. If you have trauma to the face, you have to think about anatomical difficult airway. There's a mnemonic called lemon. Mnemonic. So Malampati scoring, opening. I don't want to go into detail to that. You can. This was already covered in the previous classes. So go through that lemon assay for difficult airway. So if there's no problem with anatomically difficult airway, then you have to think of physiological difficult airway. So in this child, this physiological difficult airway is there's hypoxia, there's hypotension, and second problem is raised ICP. So there's three problems here which can which can worsen during your intubation. So you need to stabilize them before you're moving for intubation. Okay, how to stabilize hypoxia here?
Give forced pressure ventilation through bag and mask.
Okay, before going for positive pressure, bag and mask ventilation, is anything you want to do differently for this child? So this child is not only respiratory problem, child had some problem with CNS as well.
Neuroprotective measures like 3% NS.
Okay, 3% NS. That's not much time for that. So how much time you have to be 3% NS?
Half an hour.
Half an hour. So how much time we don't have here. So any other thing you want to do here? So what is the main problem when you start bag and mask in a semi-conscious child? Is it very much comfortable for them?
Irritable, it's a painful stimulus.
So it already this is with riser ICP, you cannot cause much discomfort for the child, agitation in the child. So take care that you give adequate sedation before proceeding for bag and mask. Unless child is in verge of collapse, like a respiratory arrest, there's no point of starting bag and mask straight away because 88% is absolutely fine in any different scenario. Like you have ARDS child, will accept even 85% saturations. So don't rush and start bag and mask because always the pupils are unequal. So take measures for adequate analgesia and sedation before proceeding for bag and mask. And you started bag and mask, anything you want to do differently in this scenario after giving sedation and analgesia? Keeping in the mind that the pupils are unequal.
Hyperventilation, sir.
Exactly. So think about hyperventilating this child because you are at the verge of coning. So your 3% will be start acting, but you have to give some more time for that to act. Before that, your hyperventilation, reducing CO2, and reducing CO2 will decrease the blood flow to the brain, and it can some amount of reduction of ICP can happen. Okay, and apart from that, you have problem with hypotension as well. So before giving, before going for proceeding for intubation, and you need to give a bolus by push and pull. You have to start the bolus, and even you can start inopressors straight away and maintain the BP so that you can prevent the fall of BP during intubation. Now, what is the drug of choice for sedation in this child for facilitating intubation?
Ketamine.
Propofol. Why? Why propofol? Why ketamine?
Ketamine usually raises the intracranial pressure, so it is better avoided, sir.
Okay, but propofol can cause hypotension. So already child BP is very low. It will cause further hypotension. Child can collapse. Next, someone told ketamine. Can you answer why ketamine? Yeah,
So we don't know when was the last meal for the child, and it doesn't cause hypotension also. Child is already in hypotensive shock.
okay, but the previous person has a question about ketamine rising ICP. How you are going to take care of that?
We are already hyperventilating the child, sir.
No, that is not an excuse. Because going to suture cannot cause laceration for a child. Yeah. So ketamine, now recent studies have shown that ketamine is not going to affect your ICP much. That the previous concept that ketamine will cause ICP, and now that concept is gone, and it's like a myth, previous myth. It was busted out. So ketamine is safe, and you can try it is in ICP child, and it's safe for hemodynamics as well. So that's why we prefer ketamine here, because it's a good sedative and analgesic as well. If you give midazolam and fentanyl, fentanyl is good analgesic but not sedative, and midazolam again will cause a further drop in BPs. And other drug what we can try here, if the hemodynamic is stable, is thiopental. Thiopental is a very good drug for dropping ICP. So at the verge of this unequal pupils, I will my choice here is thiopental. But the main problem here is the hemodynamics. It will cause further drop in hemodynamics. So I go here with ketamine and muscle relaxant. Muscle relaxants could be a long-acting one, like Vecuronium or Ucronium. You want to give Ucronium is fine. So, but if you have hemodynamic stable, my choice here is thiopental. So, because there's unequal pupils, so you need to decrease the ICP as early as possible. So, you can sedate and you can decrease the ICP by giving only one drug, thiopental. And so, these are the problems we identified here, and these are the interventions we started. And so, we'll move on next. Is there any doubts here? So what I think I conveyed what are the points I want to convey in a clarified manner. Is there any doubts we can discuss here? This is a very important thing. So this is the what we need to do in ER stabilization. So if you don't do anything properly here, you are going to cause harm for the child rather than benefit. So I think that's why I put so many problems in a single child so that we won't miss. Is it clear or any doubts so that we can move on to the next thing? We have to quickly move on. We are running short of time. If people understand everything here, we'll move on to the next thing. Is it okay?
Yes, sir.
Okay, fine. So we identified here respiratory failure, hypertensive shock, primary circulatory dysfunction, and reasons we know. And we will manage the causes. We discussed already hypovolemia, bleeding, obstructive pneumo, pericardial effusion. This is the most important thing we have to think when you suspect of obstructive shock. When your shock is not responding to your fluid boluses and you are drained pneumothorax, and still your shock is not getting corrected, think about pericardial effusion. How to diagnose pericardial effusion clinically?
The raised JVP and muffled heart sounds with shots.
Excellent. And the last thing is distributive shock due to your neurogenic traumatic brain injury. Reason for cerebral dysfunction, already we saw it's cerebral demand due to your axonal injury, or it could be IC bleed, which is related to cerebral dysfunction. So precaution during intubations, we know we need to stabilize manually with the release of neck collar. The senior most person who is experienced in intubating this kind of children with little mobilization of the neck. Everyone can intubate when you can extend the neck, but here we need to intubate in the position where You cannot extend the much neck, and it's very difficult situation for intubation. So don't give trial of intubation by first and second years here. So you need to have a senior most person who is experienced in intubating this kind of children. And the drugs of choice are ketamine and meconium. So we have discussed why ketamine is the choice here. And before intubation, you need to give a fluid bolus and start inopressors to stabilize the hemodynamics. So these are the precautions we need to take for intubation. So initial management. So we intubated this child with cervical spinal stabilization with collar. So breathing after intubation, you have stability somewhat improved. And circulation, we are giving fluid boluses. And disabilities, we are doing hyperventilation, and someone told to start 3%. We started 3%, 5 ml per kg over half an hour. And exposure wise, we have looked out, there is a fracture and swelling in the right thigh. So what next? What next you want to do here? Anything you want to do here?
So blood transfusion, sir.
Okay. Before blood transfusion, anything you want to do? Like how to get blood transfusion for this child? Can you get directly ask blood for this child? Or you want to do something?
Cross matching.
And matching.
By taking cross matching, any samples you want to take?
Blood gas, sir.
Yeah, good. Blood gas. Any other thing? Did investigation? There's no complicated investigations here. You can do hemoglobin platelets to look for because the child is already bleeding, and you can do electrolytes because you are already giving high 3% NS. So is there any problem with electrolytes? So you can do the basic things apart from your ABG to look for your lactates and your CO2. What is CO2 target here?
28 to 32, sir.
Oh,
30 to 35.
no. But the normal CO2
35 to 45, sir.
exactly. So I want to keep it on the lower side of the normal. 34 to 38 is the targets. Only in second tier management you are targeting lower CO2. In first tier management it's under normal ratio. Low normal. I'm not going to keep it at 40. I'm going to keep it at 34 to 36. 38 is also acceptable. So we need to look for that in the ABGs. So apart from that, someone is asked for GRBS, excellent. So we are checking GRBS, and someone has told O negative if you not get exactly. So if you have no time for a resuscitation and you cannot do cross matching, you can safely ask for O negative blood till you go for cross matching and things. Good. So we'll move on to the next. Anything you want to do apart from sending samples and asking for blood? So you can go for it.
Imaging.
What are the contraindications for your urinary cath insertion?
Suspected urethral injury.
Good. How to suspect urethral injury?
Hematuria.
Blood on the external.
Yeah.
ureter.
Yeah, blood to the external meatus or hematuria, and other thing, perineal hematoma. So these are the things where you need to suspect urethral injury and you need to avoid urinary catheter insertion. So which is preferential in gastric decompression? Is it NG tube or OG tube? And what is the reason? You want to put NG tube or OG tube, and what is the reason? If I'm asking some question, means this is some logic should be there behind. So you need to just think of that logic.
OG
In-
tube, sir.
Why?
Base of skull fracture.
So whenever you are suspecting basal skull fracture, so you should avoid NG tube because you can puncture it. So OG tube is the preferential one. Okay, this is the reassessment again. So after stabilization, so we did a great job by stabilizing the airway by intubating. So we are able to maintain the airway now. Breathing wise, or respiratory rate, we are bagging at 30 to maintain CO2s, but there's still the air rate is decreased on right side. And we have SATs around 93%. And circulation wise, still your hemodynamics are not that great. There's not much improvement. And disability wise, people are still unequal. And so what you want to do now? Why your shock is not improving even after starting fluid boluses?
Either it can be because of the pneumothorax, obstructive.
Exactly. So you are giving fluid boluses, there's no much improvement. So you need to look for obstructive. Why it's not neurogenic here? Why you're not suspecting neurogenic shock here still? Because we have seen the cause of shock in this particular child could be three. One is hypovolemic, second thing obstructive, third thing is neurogenic. So why not if people are thinking about neurogenic? Clinically, I'm not asking anything. I cannot give echo findings for you people now. So clinically, why it is not neurogenic? Dr. Bala has clearly covered this in his shock. Yeah, someone answered cold periferis. Excellent. So your pulses are low and cold periferis and prolonged CRT is the one thing again is neurogenic. Even as some part of neurogenic, that is not predominant there. The predominant variety of shock there is hypovolemic and obstructive now with this clinical scenario, clinical features. So there could be some part of neurogenic, but it is not a predominant one. So we need to stabilize the other part of shock rather than thinking only of neurogenic here. So what do you want to do? This is air rate decrease and this is a resonant note on the right side. So what do you have to do?
Needle.
You can do needle thoracostomy or you can go for ICD insertion. And so we look for improvement. And second thing is your ongoing blood loss. So we need to go for blood transfusion. You cannot keep giving multiple fluid boluses here. So you need to quickly move on to blood transfusion. So if the child is not improving with the 2 fluid boluses, the next movement you need to get the blood. There's no other go. You cannot keep repeating multiple things there. So don't think of stabilizing the child by only fluid boluses. Think about blood transfusion as well. So the main part in the ATLS management is damage control resuscitation. So you need to go for restricted use of distilled fluids because you already know it is not septic shock where the capillary leak is there. Here the reason for hypovolemia is not the capillary leak, it is blood loss. So you need to go for early blood transfusion and you need to follow massive transfusion protocol. You need to have balanced ratio of your PRBC, FFPs and platelets. If you have a whole blood, you can go for it, but many units will not have whole blood. So you need to get the packet separately and you need to follow the ratio of 2:1:1 and 1:1:1, which is preferred to you, depending on your coagulation status and platelets. So that's you can choose what is the ratio. That's the ratio is depending on your investigations. So always ask for blood at the moment when you're going to start for fluid resuscitation. Don't delay the asking for the blood. So you need to keep ready the blood the moment when you start the fluid bolus. So after completion of primary survey and initial stabilization of the chair, we'll quickly move on to secondary survey. Secondary survey is head to evaluation, complete history. It is similar to a sample history in your pulse. Apart from the sample, you will remove S here because there will be no signs and symptoms. It is only RTA. And physical examination, including the assessment of all the vital signs. You need to go for head-to-toe examination, including the assessment of vital signs. And adjuncts, you go for imaging. What are the imaging you want to do here?
EFAST.
Excellent. EFAST. In EFAST, what are you looking for? What are
Extended.
Yeah.
Hemoperitoneum.
So hemoperitoneum.
Hemothorax, sir.
Yeah, injury to solid organs. In abdomen, you are looking for all these things. Liver injury, splenic rupture. Then externalities you look for your hemothorax or pneumothorax. So these sort of things you can quickly look for even pericardial effusion as well. So include all these things, it will be extended and apart from abdominal assessment. So and next thing is you can go for apart from EFAST, what you can do in the particular child. In this particular child with low GCS,
CT brain.
CT brain.
You have to go for CT brain, no other alternative here. And for the cervical spine, you can do X-ray or you can directly go for CT spine. And for intubation, we intubated, so you can have chest X-ray to look for hemothorax or pneumothorax. So these are the imaging you will do here. But CT scan is a must for this child. So next question is, this child, you know, the alert sensorium was there, so intubated this child, ICP was there, you are going for CT chest, CT brain head. But if the child is stable, GCS is normal. So if there is any indication for head CT in this kind of children, and what are the routine indication for CT chest? Sorry, CT brain. Any child with head injury, what are the routine indications for head CT?
If the child presented with seizures or repeated vomitings.
Good. Repeated vomiting, seizure.
Bleed, sir.
What bleed?
Ear, nose, and throat, sir.
Exactly. Okay. ENT bleeds. Next.
Raised ICP, sir.
Yeah.
Opposite interval, sir.
Low GCS, you are going to do. Good.
Any focal deficit.
Exactly. So focal deficit. Any child with GCS less than 13, you need to go for CT. No other go. Persistent vomitings, sometimes with high vomitings with headache, and any bulging fontanelle or social diastasis for any infants, or seizures and ENT bleed. So this is some guidelines given by PCON network for the criteria for head CT in children. If your child is less than 2 years with GCS 14 to 15, any child with less than 13, you are going to do CT, no other go. But if your GCS 14 to 15, so look for any signs of altered mental status, like child was irritable and amnesia was there. So that kind of things you need to look for, and any palpable skull fracture. So then you need to go for CT straight away. But if this nothing is there, it's no altered mental status or palpable skull fracture, then you need to look for hematoma. Any scalp hematoma was there, and history of loss of consciousness more than 5 seconds, and the mechanism of injury is very severe. And the parents are feeling that child is not normal, parental anxiety. Then you need to take a call on whether you need to go for CT or you need to observe the child and look for any worsening, and then you have to go for CT. So that is the call you have to take based on your experience and based on other findings. If the child has multiple findings, it's better to go for CT than isolated vomitings. If the child had only vomitings, then you can wait and watch and look for worsening. But if you have multiple findings like severe headache, some scalp hematoma, then definitely you need to go for CT. And the age of the child is less than 3 months, it is better go for CT. And the parents are asking for CT, don't refuse it, go for CT. It's medico-legally, it's the safest way. If nothing, no findings are there and the child is very stable, then you can avoid CT, explain the parents. So this is for less than 2 years. If it's more than 2 years, the same thing. If you have signs for basilar skull fracture, like your ENT bleed, altered mental status, and history of vomiting, persistent vomiting, and severe mechanical injury, severe headache, then you need to take a call on whether you have to go for CT or not, like similar scenario. And if all nothing is there, then you can safely avoid CT. What is severe mechanical injury? When you expect this mechanical injury is severe, the unequal pupils is a very late side. Definitely you have to go for CT. I'm talking about CT before that. Definitely any child with less than 13 GCS, definitely you need to go for CT. So what is severe mechanical injury? Come on.
Fall from height.
Yeah, penetrating injury to the head. Accepted. Any motor injuries. So when going through highways and your motor vehicle crash with the patient ejecting from the vehicle, high-speed injuries, and if you see a death of an adjacent passenger or you have rollover injury by the car, or any pedestrian by a motorized vehicle without helmet, and fall from height. So any child with less than 2 years, the fall from height, anything more than 3 feet is very significant. Or if it's more than 2 years, anything more than 5 feet is significant. So many people will come from fall from bed. That's the most common injury for less than 2 years. So if it's less than 3 feet, I think you can better avoid a CT if otherwise child is stable. Or your head struck by a high impact injury. Sometimes a slab fall on the head. There's an axial load on the head as well. So that kind of things we need to go for CT. So crush injuries, amputation, this and all the indication for other workup. Mainly fall from height and this high impact injuries is mainly for CT. So after finishing your 5 to 7 second survey, you need to reevaluate the child. So you have to constantly look for any worsening, new findings. So then you need to act accordingly. So what are signs of rigid ACP?
Bradycardia, bradypnea, and hypertension, sir.
The very last sign. If you're seeing a child in that movement, that means you've missed so many signs. What are the earliest signs?
Vomiting.
Yeah, headache with vomiting, photophobia, some of them also diplopia. Yeah, accepted. Exactly.
Kussmaul breathing.
Posturing. Yeah, exactly. So altered breathing. So altered breathing with any other thing apart from this? Low GCS. Any child with low GCS suspect rigid ACP. No other go. So irritability also comes under low GCS. Any child with low GCS, you need to suspect rigid ACP. There's no harm in treating rigid ACP until unless the child GCS is normal. So altered sensorium with low GCS with or without posturing. Posturing is a sign of ICP. Don't take it as a seizure. Many of us will mistaken as posturing as a seizure. So seizuring is different. ICP induced posturing is different. So in this construct of rigid ICP, don't think it's a seizure and keep treating seizure by loading medications. So there you will have to intervene by reducing ICP. You need to intubate the child, you need to go for hyperventilation, 3% NS rather than giving midazolam, Levipil, phosphonatide. The commonest mistake many people will do is keep loading with anti-epileptics rather than taking measures for rigid ICP. So always think that any child altered sensorium with posturing, it is not due to seizure, it is due to rigid ICP unless or else proven. So make it a habit of stabilizing the ICP first. You can always give loading of Levipil, you can load for phenytoin, but the first thing you have to go into is stabilize the ICP. You need to control the ICP here rather than keep giving other drugs before stabilizing this rigid ICP. So bradycardia hypertension is the last thing. Unequal pupils is the very last thing. And the earliest thing is you can have headache and persistent vomitings. So keep acting at the earliest. Don't delay the management of ICP to the late. If you treat the ICP, it's no harm. You can always extubate a child. 3% is not going to harm for the child. But if you delay rigid ICP management, you're going to cause for the harm for the child. So what is the basic care for ICP? What are the basic care you want to give for ICP child?
Then elevation at 30 degrees in midline, sir.
Good. Next.
Neuroprotective intubation, sir.
Neuroprotective measures.
Represent any infusions.
Go systematically. Always go systematically. Don't answer randomly. So you want to start from system wise or head to toe wise. So start one systematically and go. Yeah, first thing is basic things. So normothermy. So neutral head positioning with head of bed elevation. So you start with head. So you have to maintain normovolivia fluids wise. If child is euvolemic, you can restrict fluids. You want to maintain normothermia because fevers are very deleterious for ICP. You can maintain hypothermia, but you cannot go for hyperthermia. And respiratory wise, your targets are you need to maintain, you need to avoid hypoxia and hypercapnia and hypocapnia as well. And you need to maintain P1 in the range of 80 to 100. and CO2 in the range of 34 to 38, and you need to go for normal or low PEEP. I prefer low PEEP than normal PEEP because your positive pressure can decrease the venous return from the brain. And circulation wise, you need to target MAP at 50th centile, not at the 5th centile. In any shock, your target of MAP is 5th centile, but in a child with raised ICP, you need to push it further to 50th centile. And per abdomen, you need to cause gastric decompression because your gastric distension can increase the abdominal, cause abdominal hypertension. It can decrease the venous return so from the brain. So always try to decompress the abdomen. CNS wise, you need to give for adequate level of analgesia, and the sedation is very important. So intubation alone is not sufficient for controlling ICP. So intubation is the most painful procedure, and one has to feel that tube in the throat, and you put your finger in the throat and see how much it's painful that thing is. So you need to maintain adequate level of analgesia and sedation. Even though the child is not moving, child can feel the pain. So always think that just giving one dose of ketamine and vecuronium is not going to sufficient. The next moment you put the tube, you need to start them on infusions, or you have to keep giving bolus doses. And anti-epileptic drug therapy. So this child doesn't have any seizure, but you want to give anti-epileptics for this child? Yes or no? There is no hint of seizure, and even you not witness the seizure. Yes. Why you want to give anti-epileptic drug therapy for this particular child?
Because the child already had primary cerebral dysfunction, and we have intubated the child, so we can do the anti-epileptic.
So what are the indications of anti-epileptic drug therapy in traumatic brain injury? What are the indications for anti-epileptic drug therapy in traumatic brain injury? So this child I accepted. You are thinking the child is altered sensorium and rigid ICP. You want to give prophylactic drug, fine. But any other indications are there? Apart from active seizures? IC bleeds, excellent. Yeah, presence of seizure is confirmed. You definitely have to give. Apart from that, so altered sensorium, IC bleeds, any other thing?
Non-convulsive seizure may occur and it can raise ICP.
That clinically you cannot do. So any child with poor GCS, you're going to start. Fine. The poor GCS will itself filter. It could be non-conscious status or into your rigid ICP. It can justify there. If child is stable, I'm asking child sensorium is normal. Then also you need to start anti-epileptic therapy or not. That's what my question here. Child with normal consciousness, still you want to start anti-convulsive therapy. And what is the exact indication for anti-convulsive therapy in traumatic brain injury? By giving prophylactically, what you are going to achieve?
Any diffuse axonal injuries?
Yeah, then child should have altered sensorium, definitely. If you have diffuse axonal injury, child should have altered sensorium. And if you have subtle small bleeds, child may be stable, that you already covered. So altered sensorium, IC bleeds, you need to cover with anti-epileptic drug therapy. Any other things? And what is the main indication here? Why you are giving anti-epileptic drug therapy? To prevent what?
Secondary dysfunction.
To prevent early onset post-traumatic seizures. Early onset post-traumatic seizure is less than 7 days duration. You are not going to do anything on late onset seizures. How much amount of epilepsy you are going to dump, it is not going to prevent late onset seizures. So, what is the role of prophylactic IDs? So, you can give for high risk children to prevent early onset post-traumatic seizures, but it's not going to help for late. And ideally, it will start within 1 hour of injury, but it can be effective in the next 8 hours as well. And the duration of prophylactic AED is only 7 days. It's not for lifelong, and it's not for months together. So once you can cross 7 days and there's no active seizures witnessed, then definitely you can straightforwardly stop. There's no tapering AED there. If it's less than 2 weeks duration, you can straightforwardly stop the drug. And the drug of choice here is?
Levetiracetam.
So phenytoin is the age-old drug, which is a drug of choice for many neurosurgeons. But now the Levipil is taking over. So you can choose phenytoin and Levipil depending on the availability. So you need to load it. No, don't start with maintenance doses directly. You need to load it. But previously the treatment is you need to start the maintenance therapy directly. But here you need to start the loading, then only you need to go for maintenance, and you can stop it at the end of 7 days if there's no seizures. And what is this high risk children? High risk children is disease less than 10, cortical contusions, circle fracture, there's a hematoma, it could be subdural, epidural, intracerebral, and this is a penetrating head wound, focal deficits, and there's a prolonged duration of post-traumatic amnesia, and there's a retained bone or metal fragments in the brain. So these are the risk factors for developing post-traumatic seizures. And if you have any one of them, not all of them, if you have any one of them, so you need to go for prophylactic anti-epileptic drugs if the child consciousness is 15/15 as well. So if it is 15/15 also, if you have any one of the thing, you need to go for prophylactic AEDs, and you can stop it at the end of 7 days if there is no active seizures after that. And so hematological metabolic wise, what you want to do in raised ACP control?
Euglycemia, sir.
Yeah, euglycemia. Electrolyte.
Target sodium between 145 to 155, sir.
Excellent. And hematologically wise, the target of HB should be at least 7. And if child is very unstable and your verge of toning, you can even target more than 10. And you treat the coagulopathy because this child can bleed further. You need to correct coagulopathy and target sodium, normoglycemia 80 to 180. And even after this basic ICP measures, if your ICP is not under control, you need to go for second tier therapy. Second tier therapy is mainly you need to start barbiturate infusions. And if you've done CT scan, and if CT scan showing any mass like IC bleed or subdural hematoma or EDH, then you need to go for surgical intervention and removal of the mass lesion. And if there is no removable mass lesion, then you need to go for medical management. Medical management, the main medical management is the barbiturate infusion. And going upon the osmolarg therapy, you can target sodium 155 to 165. In first tier, the target is 145 to 155. In second tier, it can go up to 165. And you can hyperventilate to decrease the CO2 further to 28 to 34. In second tier only, your target CO2 is less. The first tier, it is 34 to 38. It's not less than 34 in first tier. And you can go for moderate hypothermia in the second tier therapy, 30 to 34 degrees centigrade. Barbiturate is thiopental infusion. You can start thiopental infusion by giving a bolus 3 to 5 mg per kg, and you continue the infusion of 2 to 8 mg per kg per hour. So that is what you can do. So these are the measures you need to do when your ICP is resistant to your first tier therapy. And if your ICP resistant to second tier therapy, your cerebral device worsening, then you can go for decompressive craniectomy. That's the last resort what you have if your medical management fails. So hopefully our child recovered without decompressive craniectomy, and we stabilized the child with blood transfusion, taking for surgery and opening the thigh, stabilizing the femur fracture. And this particular child had femoral artery transection. So we've done the grafting with cephanosphene, we've done the grafting of femoral artery, and finally this child survived and went home. So any questions? So I think I have given some points what you can take home and practice even in peripheries. So I make it very clear, simple. I keep it simple so that everyone can practice the things. And I put that video in the group, so please go through the video and make sure that you have available, make available the cervical collars in your peripheral centers as well. And so which aid is preferable, that's your choice. So if you are very familiar with phenytoin, go with phenytoin, and if you have available Levipil, go with Levipil. That depends on your, because you are not going to load it faster. Here the main issue is you are going to load it slowly only. No need. If you status epilepticus, the choice is Levipil. There is no other go. You need to control the seizure as early as possible. If you have Levipil is available, I go for Levipil. My vote is for Levipil. But in this situation where you can load it very slowly also, even you can try phenytoin. The studies have shown that both are equally efficacious. So the choice is up to yours, whether you want to go for Levipil or phenytoin in this particular scenario where there's no seizures. But in case of status epilepticus, my choice is Levipil. You have to give it in 5 minutes, not in 20 minutes or half an hour. Push the Levipil in 5 minutes, that to 40 to 60 mg per kg, not 20 mg per kg. So that's what I am going to stress again, status management. Go for Levipil and do it faster way. So please practice it and don't forget about cervical spine stabilization when you're referring a child with head trauma. I have seen many referrals without cervical spine stabilization, and even secondary level, cervical spine stabilization is very easier. At least you can put an NS bottles adjacent, you can strap the head. So that is what you can do. And most important thing I forgot is log roll. When you are putting something and you are moving something from the bed to stretcher to bed, you have to make sure that you have a spine board, which is a stronger one, which you can keep under the body so that you won't affect the spine. So make a habit in the peripheral centers as well to use the cervical scholars and spine board. It's not costly. Definitely I can say they're not costly. So you can use this at least this NS bottles with head strapping before shifting the child to surgery centers. Any doubts will take, I will stop the session here. Thank you all for the participation and the interaction.